Hello, my name is Adam Singer and I'm a diagnostic radiologist from Atlanta, Georgia, and today I'll be discussing imaging of the pectoralis major and injuries related to this muscle and its tendon. Quick disclaimer, this video and all the videos on my channel are for educational purposes only and should not be used to make medical decisions. If you have a medical concern, please consult your provider. So there'll be 4 learning objectives today. The first is to review the MRI anatomy of the pectoralis major. The second is to compare that with the sonographic anatomy. The third will be to show cases of injuries and then example MRI protocols for rule out pec tears and really emphasize how the field of view is important. And then I'll briefly touch on management. So moving into the anatomy, this is an image taken from Gray's Anatomy. This is a surface rendering of the pectoralis major muscle anatomy. And you can see there are 2 main portions. There's an anterior and cranial clavicular head coming off the medial clavicle. And then there's a much more broad, larger sternal portion coming off the sternum and portions of the ribs and the costochondral cartilage region. And you can see that there's sort of a twisting mechanism of this sternal component as it comes up towards the broad humeral attachment. And note that it is somewhat posterior with respect to the clavicular portion. The other muscles in the immediate general vicinity are the deltoid muscle, and there are multiple bellies, but the anterior belly is right next to the clavicular portion of the pectoralis major, and in this groove, the deltopectoral groove, will run the cephalic vein, so you can use that as a landmark. As you come towards this broad humeral attachment, there are several muscles in close proximity. Medially, the coracobrachialis, and as we start moving laterally, the short head of the biceps breaking, and then the long head. If you look posteriorly, you'll see a little bit of the latissimus dorsi here. So this is a surface rendering of the muscle anatomy, but as you know, MR is cross-sectional, so we're cutting across the anatomy, and so you have to take into account this anatomy as you're going through and scrolling through these structures because you're getting slices of them instead of looking directly at them. So we'll start with the axial images. This is an axial proton density fat-sat pulse sequence. I tend to use this as the workhorse when I'm looking at pectoralis injuries, just because we're seeing the pectoralis tendon along its long axis all the way to the insertion. Notice that there is some respiratory motion here. You see these lines coming across, and that is because this patient is supine and obviously breathing. So one way to try to reduce that is to have them prone when you do these images. So a lot of arrows here. This is the cranial slice, the caudal slice, but let's break these down and explain what we're looking at here. So we'll start with the cranial portion. We have the pectoralis muscle here in red, and so this is anterior and cranial, so this is going to be portions of the clavicular head. We have the anterior belly of the deltoid, and I know that because I can see the cephalic vein in the deltopectoral groove. We see the beginning of the top of the pectoralis major tendon here, and then underneath that we're going to see some of those medial muscles, so the coracobrachialis down here, the short head of the biceps here, and we're seeing a little bit of the long head beginning to fan out and become the musculotendinous junction. We also have this thin tendon coming through here, attaching medially from the pec insertion, and this is going to be your latissimus dorsi tendon. As we scroll a little more inferiorly, again you can see the movement of that cephalic vein, showing this is the deltopectoral groove, anterior deltoid, pectoralis major muscle. We see another muscle here, which we could actually see on the prior cranial slice, but you see it a little bit easier here, so I labeled it here. This is the pec minor. It runs under the pec major. And we see that biceps, the long head, starting to fan out at that myotendinous junction. So here is the beginning of the long head. This is the short head here, the coracobrachialis underneath, and the pec tendon attaching here, this dark tendon attaching down to the humerus. And as we come across and medially, you'll see that latissimus dorsi coming across here, and then you'll see the teres major behind that with a direct muscular attachment to the humerus. So that's the basic anatomy as you're scrolling through here on the axial images. Sagittal and coronal are a little bit more challenging. I put up these localizer images for both of these cases just so you can get an idea of our slices as we're going through. You are cutting through in short axis on this slice, and so you're seeing the tendon here. But as you start coming out towards the attachment, you note that it becomes more obliqued, and so it's a little bit harder to see this attachment here, but here it is coming in. And if you come further medial, you'll actually see the latissimus dorsi tendon coming across here. So here's this latissimus dorsi right here. On the coronal images, this was actually a sternal protocol, but you can see the medial pectoralis muscle anatomy pretty well here. So this is an anterior slice and a more posterior slice, and you can see the separate clavicular head coming off the medial clavicle here, and the beginning of several of those sternal head fibers coming off the sternum here. As we scroll posteriorly, you would expect to not see as much clavicular, but you do see more of that sternal portion because the sternal portion is more posterior, and indeed you are seeing more of those sternal slips coming off here. I showed an axial correlation to the coronal here, so this axial slice is basically the image right here, and you can see coming off the clavicle is that clavicular head more medially here. We're not down to the sternal portions yet on this axial slice. As you come towards the attachment, it becomes challenging again. Depending on where you are on your coronal slices, you are potentially going to have volume averaging with the humeral cortex, and it takes an oblique course, so it's a little bit harder to see, but here is the tendon coming in and coming into its attachment there. Alright, so now let's look at the sonographic anatomy, keeping in mind what we have just learned with our surface rendering and also our MR anatomy. So here is that more caudal image here, and here is the corresponding ultrasound image, and you can see the humeral cortex here, this echogenic portion of the bone here. You get some shadowing in the shaft region, and you can see this echogenic fibrillar structure coming across from lateral here towards medial, so this is going towards the sternum. This is the pectoralis major tendon here. You're beginning to see that myotendinous junction of the long head of the biceps tendon. Here's your short head, and you can see a little bit of the short head tendon, the coracobrachialis underneath here. So these are our corresponding images, MR and ultrasound. And here is a panoramic view, so you're seeing a little bit more of the pec in this case. Again, the humerus over here, the tendon here, and we're going back to the myotendinous junction and into the muscle here. You can see the deltopectoral groove here. The field of view is a little large, so it's hard to see this vein here, but this is going to be your anterior belly of the deltoid and your pectoralis major over here. You can use the ultrasound to confirm that though, and so this is a little bit blurry, I apologize, but here's your anterior deltoid and your pec here, and there's the vein, and if you watch, we're going to scroll through in a second and see this vein collapse with probe pressure and reappear. So there's a vein, you squeeze it and it goes down with this vein. And if you don't believe that image, we can go, and this is with augmentation. Here's the vein here, and when I squeeze and contract muscles in my forearm, you can see that there is flow in that vein right there. So this is augmentation, just showing this is the cephalic vein in that deltopectoral groove. So now we'll move on to showing some cases and example MRI protocols for rule-out pec tear requests. I'm going to actually start with the protocol portion first, and then I'll get to the cases. So I wanted to emphasize the importance of selecting the correct field of view. So these are different fields of view, going from smaller to larger, and you can see here's your 20 by 20, 22.5 by 22.5, and 28 by 28. You see more anatomy as you get a larger field of view. So in this case, you're seeing all the way from the humerus over to the sternum, the entire pec muscle. You're even seeing some of the contralateral pec. Over here, you're not seeing as much of that pec muscle here, and this is somewhat in between. But if you look carefully at the images here, you'll note that you get a little bit more of the spatial resolution and more detail when you look at smaller field of view images here. So you're seeing more of the anatomy of these muscles when you compare to a larger field of view where it just sort of blurs a little bit. So you want to look at your patient. You want to, when you're planning your scouts, try to figure out exactly where you think the injury is, and if you're not sure, you probably should go with imaging the entire muscle, but focus on this area. This is going to be the surgical area out here. You definitely want to make sure you get good images out here. Typically it's going to be more non-surgical over here. And keep in mind that the more you open your field of view, the more incidental findings you may find. So you're going to get a good part of the left lung here that you're going to have to worry about, and some of the mediastinum as well. So if you don't want to find incidental things, you don't want to open the field of view. So this is the MRI protocol we're using. We are pretty reliant on proton density fat side imaging. So we do 3 planes, PD fat set, and we typically will, on average, go for this 22.5 by 22.5. Although, depending on how big the patient is, and if we think that there's a more medial injury, we may expand that field of view. For our coronal and sagittals, we do expand the field of view, and then we typically do a T1 just to look at the marrow as well. So here's an idea of the scout images that we're using to plan our diagnostic images off of, so you can get an idea of the orientation of your coronal and sagittal here. And you want to make sure that your slices go all the way anterior to cover the entire muscle here. So if you stop here in your coronals, that's really not sufficient. Same thing in your sagittals. You want to come all the way over, so you need to make sure your field of view covers the entire muscle. All right, so now before we move on to the final part, the management, I'm going to get into the cases here. So I'm going to start with this one. So this one did not have a pectoralis major injury. You can see the pectoralis major tendon attaching here, fanning out into the sternal component here, and the clavicular head more anteriorly here coming off the clavicle, the deltopectoral groove. Here's that cephalic vein, anterior deltoid. And as we scroll down, you can see the long head of the biceps tendon sort of fanning out and beginning to have your myotendinous junction here. So here's your long head, your short head, your coracobrachialis, and you can see the latissimus dorsi right here. This actually had an old latissimus dorsi injury if you follow this all the way back down into here. So this would be more of a normal appearing pectoralis major, the pec minor underneath here. Then we're going to start going into some of the injuries here. So here's a patient who had a smaller field of view, and we really didn't initially image down low enough when we were planning. You can just see a little bit of the pec tendon here, but you can see that there's a little bit of edema out here, so we really needed to open up the field of view a little bit more and get a better idea of what was going on medially. But at this point we can say we don't, at least on these images, see evidence of a distal or humeral attachment injury or intratendinous or peritendinous or musculotendinous injury here. So now we open the field of view, and you can see a little bit of that tendon coming in, but as you scroll out more medially, you can see that there is a tear with a small area of hemosiderin or hematoma in this portion of the sternal head of the pectoralis major. So this is an intramuscular tear. This was something that could potentially not be repaired because it's really not at the tendon where they typically do surgery. So here's your tendon here. You can see that that is intact, and this is a intramuscular tendon-less injury, so intramuscular. This would be a strain. Here's another case here, and you can see the pectoralis major tendon here intact. We didn't really go out far enough to assess the muscle here, but there's an awful lot of edema here. You can see it tracking around the coracobrachialis and biceps, but the tendon is intact, so this is probably a low-grade strain at the myotendinous junction of the pectoralis major. This was a non-operative case. So here's another case, and you can see this feathery edema with a small hematoma in the muscle, and the injury seems to be centered at the myotendinous junction region here. There's a partial thickness tear, but it is not complete. Much of the tendon remains attached to the humerus here. You can see it has not pulled off from the humerus. This is not a humeral avulsion. This is not a tendinous injury. This is more of a myotendinous partial thickness tear. And here's another one. We can see portions of the tendon here attaching to the humerus, but we can see tendon sort of flopping around here within a hematoma at the myotendinous junction, and some probably blood products back at the muscle here. So this was a high-grade, near full thickness tear of the sternal head involving the myotendinous junction here. Maybe portions of the clavicular head still coming through here. And here's one more. We can see the tendon attaching to the humerus. You can see the latissimus dorsi behind that. And as you follow it back towards the myotendinous junction, you start to see some feathery edema, and there is an intramuscular tear with hematoma out here. So again, not a humeral avulsion, not a tendinous injury, more of a myotendinous and intramuscular strain here, partial tear. And in this case, we have the ultrasound. You can see that tendon coming through here and attaching. We're seeing some anisotropy at the long head of the biceps, the coracobrachialis and short head over here. But we do see the tendon attaching here. And as we start scrolling out medially, we're getting towards that injury. And when you see the panoramic view here, you can see that distal tendon coming in here. But as you get to the mountainous junction, it becomes a lot more heterogeneous. And then you can see that hematoma and distortion of the normal muscular anatomy where that tear was located. And now just to show some of the higher grade injuries, this is a complete avulsion from the humeral attachment, and you don't see any of the tendon coming down in this case. You do see retracted, sort of redundant tendon back here. It's retracted back to the mountainous junction. There's feathery edema in the muscle back here. We can see some hematoma here, and so this often shows up clinically, by the way. When you see these patients acutely, there will often be ecchymoses and bruising in this region here, and sometimes you can actually feel a palpable cord where that tendon stump is. Often, another sign of a complete humeral avulsion is this significant fluid or edema around the long head of the biceps tendon. It's often elevated away from the humerus, and that may be related to removal of the restraint from the tendon and also injury to the biceps sheath and stabilizing structures. So when you see this fluid around it and this elevation, you want to start thinking about the potential of a pec major humeral avulsion. And look for that tendon. And so this is a case of a complete avulsion from the humerus. Sometimes this is associated with a piece of bone. And here's another case here. Again, the fluid around the biceps, it's elevated away from the humerus. You may see a little bit of the stump of tendon coming down here, but there's no tendon continuity coming all the way back like we saw in the earlier cases. And instead you see this redundant tendon back here, retracted back with a lot of muscle edema and maybe a little hematoma down here. So this is another tear. In this case, if you want to call it a tear from the humerus or the tendon just proximal to the humerus, but it's a complete tear. And one more case here. We see a large hematoma right here, disruption of the normal muscular architecture with this intervening blood products and edema. The biceps tendon again elevated away with lots of fluid around it, and we have no evidence of a tendon coming in and attaching. You do see the latissimus dorsi, so you don't want to mistake that for your pec tendon, but there's no pectoralis major tendon coming across here. And you may start to see some of that retracted tendon back here. So I haven't shown any other views other than the sagittal here, so I want to show the sagittal here because it's good to correlate. And also there's a teaching point here. So you do see that tendon retracted back here, and you can see the muscle back here with the hematoma. So unlike the normal that we saw earlier in the anatomy part, you don't see it ever coming over and reaching to the humerus, and it's redundant and really just stops right abruptly there. Now you may say to yourself, well, we do see muscle coming from the region of the medial clavicle and attaching to the humerus here, so there must be the clavicular head intact, but if you look carefully you can see that there is the deltopectoral groove right here, and here's your cephalic vein, and this is anterior deltoid. So your clavicular head fibers are torn here as well. They really are not reaching where they should. So look for your cephalic vein, look for that landmark if you're questioning whether or not there may be portions that are still intact. And one final case here, we again see the elevated biceps tendon, the fluid around it, but something a little unusual about this biceps tendon, it looks pretty big and somewhat wavy. So you can have other injuries that occur and it's not just the pec, and so this was a biceps rupture that's retracted. There also is a pec complete humeral tear as well, though there's no tendon attaching here. You can see the hematoma back here and some retracted tendon and muscle back here. So keep in mind that when you make your diagnosis of a pec injury, you don't want to just stop there. You want to look for other injuries that may have occurred either at the time of the trauma that caused the pec injury or even prior to that, because a lot of these patients, as you can see from the cases I'm showing, are athletic, tend to lift weights, and may have other coexisting injuries. All right, so we'll come back to where we were. We're going to come to the last objective, which is to briefly touch on management. So there's been a lot written about how to manage pectoralis major injuries. Here's a review article from the Journal of Shoulder and Elbow Surgery. That would be one good resource to look at, but there's many different papers out there. And in general, when we talk about is the patient going to have surgical or non-surgical management, surgical management will take into account clinical factors and factors related to the injury. And so clinical factors that often are taken into account include the age of the patient and mobility and function. So if they're a younger, athletic, more functional patient, they may lean towards that operative group. If there are cosmetic issues that they're concerned about, that may be another reason to push for surgical intervention. Chronicity is important, so if it's more acute, there is an easier repair process and outcomes are good. There are papers out there that suggest that even some of the chronic injuries may have good outcomes too, but in general, the more fresh the injury, the easier it is to fix. And these surgical interventions in the literature have reported good outcomes in terms of functional recovery. So then the other part of this is going to be where is the injury. So there are areas that are more prone to surgical intervention. These are going to be the more lateral portions of the pectoralis major. So the direct humeral attachment, the tendon, and the myotendinous junction. And so the tendon itself can rip off. The tendon can rip a piece of bone off and come back. You can have a tendon tear in between the attachment and the myotendinous junction. You can have a tear in the myotendinous junction. And so these areas may be more likely to have surgical intervention in the appropriate clinical setting. Injuries more medial in the muscle and at the medial attachments are less likely to have surgical intervention for those. So you want to take into account the clinical factors. You want to describe where you're seeing on MR the injury, and then you also want to try to get an idea of how much of the tendon cross-sectional area is involved. And so you're going to have to use your axial and your coronal or sagittal planes to try to get an idea. And so there's not an exact number, as far as I'm aware of, that surgeons look at to say this is the threshold for surgery and this is below threshold for surgery. But typically you're wanting to look for a higher grade tear, so a full thickness tear greater than 50% cross-sectional area. Those are going to be more likely to push towards the surgical intervention. So that would be the third piece that you're looking at when you're trying to overall assess the situation to determine is this going to surgery or not. The surgical treatment for this is typically going to involve placement of suture anchors in the humerus at the native attachment of the pectoralis major, and then suturing the tendon back down, or in the case of tendon that's not of good quality, you may see allograft augmentation to augment the strength of this repair back into the humerus. All right, I hope you liked that video. If you have any questions or comments, please put them in the comment section below. If you have any other things that you would like to be discussed, also put that in the comment section below. Don't forget to hit a like down below. And if you haven't subscribed already, hit the subscribe button and the bell button so that you get notifications when new videos go up. They're going up about a week to every other week now. So thank you very much for your support, and I look forward to seeing you next time.